Thank you. So many thanks for asking me to speak about acute leukemia in pregnancy today. I'm Michelle Lannon. I'm one of the consultant haematologists at the Freeman Hospital in Newcastle Upon Tyne in the north of England. And I specialise in acute leukemia, both ALL and AML, and bone marrow failure syndromes. And thankfully, because leukemia in pregnancy is rare, my disclaimer is that I'm not an absolute expert in leukemia in pregnancy. I may be an expert in leukemia, but given how rare the events of seeing leukemia in pregnancy are, it's very difficult to become an expert in leukemia in pregnancy. But there are certainly threads and trends in these patients that you can follow through for the rare numbers of patients that we do see. So I'm going to start off by doing a case discussion of a case that we managed recently of ALL in pregnancy, acute lymphoblastic leukemia, and how we managed it within the UK system. We'll then draw on some key points in the management of patients with acute leukemia in pregnancy and think about the diagnosis and management where resources may be limited and key considerations. And we can maybe open that as a discussion if people are willing to contribute. So we'll start with the case. So this was a 29-year-old nulliparous female who presented to us in November of 2024. She'd lived in the UK for 2 years, but originally came from Nigeria, and she was 31 weeks pregnant at presentation. She presented because she'd had worsening anemia through her pregnancy, and initially that had been all that was present. But around about 30 weeks, the midwife had noted that she'd become thrombocytopenic and her platelet count had fallen to 70. At presentation, then, her peripheral blood did show blasts at this time point, so it was evident from the beginning that there was something serious going on. Her white count was 5.28, platelets of 59, and her hemoglobin was 98 at diagnosis. On further testing, we discovered that she had Philadelphia positive B acute lymphoblastic leukemia. And whilst it's not easy, she was at a point in her pregnancy where the pregnancy was viable. So with careful counselling and consideration and discussion in our MDT, including with the obstetrics team, we made a call to proceed with what we would deem to be our standard management, which is the UCAL 14 protocol, which is mixed chemotherapy, and I'll come on to show you in a second. We did, however, discuss some important modifications due to the pregnancy to try improve the chances of the pregnancy continuing successfully, and also to try and reduce the risk to mum and to baby. So our aim was to deliver chemotherapy that was safe alongside the pregnancy, and to have frequent monitoring of mum and baby throughout. So just as an idea, this is the UK protocol that we have. There have been some changes and modifications to it recently, but for those who are Philadelphia positive, this is essentially what we would follow. I put this here just to demonstrate the point that it's complex and that there are many drugs involved in this chemotherapy regime, and many of which would not be safe to administer during pregnancy. So we had to have a look at our standard protocol and make a call on what we thought would be the most appropriate drugs to proceed with. But in general, the principles of our ALL treatment protocol in the UK is we give induction treatment to induce a remission, and then consolidation and intensification, so that once a remission is achieved, that we get the deepest response that we can, and we're aiming for a measurable residual disease negative remission. Patients then go on to 2 years worth of maintenance with regular chemotherapy, and which is much less intense than the first 6 months of treatment, and that's with the hope of maintaining a long-term remission. So for this patient with Philadelphia positive B-ALL, we looked at the literature and we discussed it with obstetrics, and there are many case reports of using low intensity treatment in Philadelphia positive ALL, using steroids and vincristine or other vinca alkaloids only, which is safe to do so in the second and third trimester of the pregnancy. Whilst imatinib has not been studied for the use in ALL in pregnancy, it's been extensively studied in patients who have got chronic myeloid leukemia. And the imatinib TKI has got a good safety profile. And whilst it's not recommended for use in pregnancy, there is good data to support its use. We omitted what would be additional add-ons to the induction chemotherapy, so daunorubicin. So we removed the anthracycline chemotherapy due to the risk of significant cytopenias in mum and therefore in baby, and the risk of cardiac complications both in mum and in baby. And like I say, there is good documented evidence of inducing a remission just with steroids and vincristine alone. The patient did not have any neurological symptoms to suggest CNS involvement, but we didn't want to risk systemic absorption of methotrexate from intrathecal therapy, as this would be contraindicated, and so we did omit this from the induction chemotherapy. We do give standard antimicrobial prophylaxis, and this we did consider and check with the maternal medicine team, and we went with our standard antimicrobial prophylaxis with antifungal ambisome and acyclovir for antiviral prophylaxis. And normally we would give cotrimoxazole to reduce the risk of opportunistic infections, but this is contraindicated in pregnancy due to its antifolate metabolism effects. So we used azithromycin to try and reduce the risk of infection. The aim from the outset was to try and get this pregnancy through to 34 to 37 weeks gestation before delivery of the baby. And so we had to liaise very carefully with our obstetric colleagues and with frequent monitoring of mum and baby in order to ensure that we were making the right decisions continually throughout the process. The patient needed some supportive platelet transfusions. And in the UK, the protocol would be to give CMV negative selected products. So we gave her platelet transfusions. She didn't actually need any blood transfusions during her treatment. And thankfully, the period of time with cytopenias was short-lived. Through the induction chemotherapy, her blood counts improved significantly just with the steroid vincristine weekly and imatinib targeted therapy. And we were shocked to find that actually she was able to enter a MRD negative, very deep remission after that first cycle with a modified chemotherapy approach. Once her platelet count recovered, we gave her tinzaparin prophylaxis, so thromboprophylaxis to reduce her risk of thrombosis, given that she was pregnant and had cancer. And the plan was for an induced vaginal delivery at 37 weeks, which proceeded at 37.4, and with very manageable complications. She had a secondary degree tear and there was a small blood loss, but otherwise she delivered a very healthy baby girl with minimal complications. After the delivery, she did actually have a fever and so was treated with broad spectrum antibiotics, and so was baby. But actually mum and baby remained well, and there was no ongoing antimicrobial treatment required. She was started on some iron supplementation due to the minimal blood loss, such to try and support her treatment moving forward. After delivery of baby, we gave her a little bit of a break from the treatment, given that she was in a very deep remission, but proceeded 3 weeks after delivery with the next block of chemotherapy, given that she had recovered well at this time point with complete healing of her wound from the tear, and her blood counts were excellent. So we went ahead with our next phase of treatment, which included cytarabine and cyclophosphamide, and we actually switched her imatinib to ponatinib, which is a third generation TKI, due to side effects from the imatinib. She had a lot of gastrointestinal side effects, feeling sick after, for several hours after taking the imatinib, which is quite commonly seen. But we wouldn't have been able to do that during the pregnancy, as there's very limited safety data for the use of ponatinib during pregnancy. We were then able to get on with some intrathecal chemotherapy with methotrexate as well in order to protect her central nervous system. Um, and from there on, really her treatment had continued quite uneventfully. Um, she completed her second block with all of the standard protocol without any modifications or adjustments. We did, however, switch her vincristine to vinblastine due to the presence of peripheral neuropathy, which she had encountered during her induction. And she remains, even to this day, in an MRD negative remission. So her very limited chemotherapy during the induction entered her into a deep remission, and that has been maintained. At this point in February last year, we then discussed the risks of chemotherapy on fertility and premature menopause. The focus had very much been on safe delivery of the baby that she was pregnant with at the time. But we have then gone on to have further discussions about what it will mean for her in the future, and that perhaps once she's completed her chemotherapy, if she wishes to think about more children, then we should refer her to the fertility centre for assessment of residual fertility. Her baby girl is now 14 months old and is developmentally ahead of her months, we're pleased to say. And it's always a relief for me to see them in clinic with her little baby girl who's very healthy and developing in a way that is ahead of her months. So that's very reassuring to see, given that we had treated with chemotherapy during the pregnancy. So the considerations that we had in the when she presented, so as part of our standard protocol, we would normally do a 4-drug induction. So we would do daunorubicin, azanthracycline, vincristine, dexamethasone, and intrathecals. For those that are Philadelphia negative, they also get pegosparaginase, and that would be completely contraindicated in pregnancy. But for Philadelphia positive disease, this was already contraindicated. If you see on the right here, given that she was 31 weeks pregnant, we did a 3-drug induction, omitted the daunorubicin due to the cardiac risk, and did give the other drugs with vincristine, dexamethasone, and a TKI. And we carefully monitored her for diabetes due to the steroid risk. In terms of prophylaxis, this is what we would normally give alongside this induction chemotherapy. So our antiemetics would be ondansetron and metoclopramide, acyclovir to prevent cold sores and VZV, ambisome for fungal prophylaxis, and cotrimoxazole for opportunistic infection prophylaxis, and tinzaparin when appropriate when the platelet count recovers. We modified our drug prophylaxis such that she had cyclizine for antiemetics, which was effective. We continued with acyclovir and ambisome, given that it was safe in pregnancy, azithromycin to replace the cotrimoxazole, and tinzaparin at the point of platelet count recovery. As I've mentioned previously, we omitted the intrathecals due to the risk about toxicity from systemic absorption of the intrathecal methotrexate. Just a note about how we dosed her treatment. So it's generally suggested that you dose on actual body weight, and the actual body weight at the booking appointment was used for the initial treatment and modified thereafter based on actual body weight through the pregnancy. We only gave 1 cycle of treatment during the pregnancy, as she thereafter delivered the baby safely. But if we had to continue during the pregnancy, we would have reassessed at each appointment with her weight and made adjustments appropriately. Okay, so my reflections on this case in the UK model: how can we best utilise obstetric and haematology MDTs to support pregnant patients diagnosed with acute leukemia? Well, the things that I learned were to collaborate, to work with the rest of the other specialties involved, and to lean on their expertise because we're not expected to know everything. And every patient is different, so nobody ever really fits a textbook plan that you set. And that if it's possible, if you've got different skill mix, to do joint consultations. So it worked very well for us to have haematology and obstetrics in the same appointment in order that we can, in real time, collaborate and discuss a best plan to move forward. And it was really important for us to document clearly what was to happen during the pregnancy, both for mum and baby, and that those notes were available to both the team treating from a leukemia point of view, but also the obstetric team planning for delivery of the baby. Um, Other reflection, what should prompt the obstetric and midwifery teams to consider further investigations in a pregnant patient? Well, as I'm sure you're aware, it's very, very common to see cytopenias in pregnancy. So if you are doing routine blood counts and you find that someone is anemic or you find that someone has got low platelets, what would trigger you to consider that there could be something else going on? So in terms of blood counts alone, things that would trigger for me would be that if there is more than one low blood count, so if you've got anemia, thrombocytopenia, or thrombocytopenia and neutropenia, that would trigger for me. Many patients have a platelet count that is suboptimal in pregnancy, but for the vast majority, their platelet count will remain above 100. So if a platelet count was less than 100, that would concern me. If the counts are continuing to fall, I guess, again, trending is important, and neutropenia. So neutropenia is rare in pregnancy, and I'll come on to discuss that in a second. Due to the sort of more inflammatory response that you see in pregnancy, you tend to get a neutrophilia. In the UK, there are nuances to blood product support for treating patients during pregnancy, and it is recommended that patients receive CMV negative blood products during pregnancy due to the potential risk of congenital CMV in the neonate. But it's generally accepted nowadays that leukodepletion is likely to be effective, although has not been confirmed in testing to reduce this risk. So if it was an emergency situation, we would give non-selected blood products, non-CMV selected blood products, because the hope would be that leukodepletion would capture any risk. And if this is a case of ALL, but if it was AML, the risks I do think are different. So the treatment intensity is different during the induction. And I would say that daunorubicin and cytarabine are a risk at all stages of pregnancy. But of course, we would consider the risks as a balance depending on the situation. And with this chemotherapy, the level of cytopenias are likely to be much more severe and prolonged. And so we probably would consider early delivery in these patients sooner than that of a patient with ALL, given that during the induction, they're likely to count recover very quickly. So just a note on acute leukemia in pregnancy. So the incidence is very, very rare. So the incidence is 1 in 75,000 to 100,000 pregnancies. Two-thirds of those cases will be AML and one-third ALL, although my experience recently from my clinical practice is that all of the patients that I've seen in the last 2 years have had ALL rather than AML, which is a little easier to manage than AML in pregnancy, although they all bring their own complexities. The most common peripheral blood features are anemia, thrombocytopenia, and neutropenia, which again, as we've discussed, you can see anemia and thrombocytopenia in pregnancy normally. And the symptoms of acute leukemia, there's so much overlap with pregnancy. So fatigue, shortness of breath, pallor, nausea, bleeding gums, nosebleeds, infections, sweats, etc. And so it can be really difficult to tease out those patients that you think that have symptoms that are out of keeping with a normal pregnancy. Other symptoms that patients may present with could be DIC, depending on the type of leukemia, leukostasis, if they've got a very high white count, so pulmonary leukostasis or strokes. PV bleeding, again, could be normal in pregnancy or abnormal in pregnancy, but there may be another cause for it, and sepsis. And just thinking about the frequency of cytopenias in pregnancy, it doesn't make it very easy. So, just over a third of patients will be anemic during their pregnancy. And thrombocytopenia is very common. So, about 12% of pregnancies will have some level of thrombocytopenia. And this is mostly due to gestational thrombocytopenia. But less than 1% of these will have a platelet count less than 100. So hence why I've flagged that if a platelet count is less than 100, that is likely to be pathological in some way, and not part of the normal pregnancy process. Neutropenia, I've mentioned it's rare to see in a healthy pregnancy, and that's due to variations in neutrophil count during the pregnancy. So you do normally get a neutrophilia, which would be normal as part of a pregnancy, but it is worth noting that normal neutrophil ranges may vary due to ethnicity. So I don't think that's projecting very well, but this is just a sort of paradigm to get us thinking about, no matter what we do here, there will be risks involved. So if we start at the bottom, we've got our chemotherapy. Chemotherapy obviously poses risks to all patients, not just those that are pregnant. But when we're dealing with pregnancy, we're thinking about mum and baby and have to think about what drugs would be allowed according to the trimester of the pregnancy. And whether we're talking about the risks of the chemotherapy or the risks of the leukemia itself, it has an impact both for mum and the pregnancy and the baby. And whether we're talking about the risk of the leukemia or chemotherapy, the risks for the pregnancy are quite consistent. So, spontaneous abortion of the pregnancy, stillbirth, intrauterine growth restriction, and preterm delivery. So in the UK model, these were the people that we had present in our MDT. But we're very lucky that we had all of these expertise on hand, given that we work in a tertiary centre in the UK. And we had people who had expertise in managing leukemia and pregnancy. So the obstetrics team with a specialist midwife, a leukemia consultant, a leukemia nurse specialist. We had neonates involved, and we had a pharmacist both from obstetrics and haematology, and an anaesthetist. And we were fortunate in this situation that there is a national ALL complex cases panel where I was able to discuss this case and lean on some of the national experts for support and advice. So when I was thinking about this patient and what my priorities were for her and for the baby at presentation, we first off for mum, we got diagnostics. So we did a full screen of blood tests, and I've highlighted and read the ones that I think would be most important if you were unable to do the rest. And it's just worth noting that I don't know what resources available, and we'll go on to maybe discuss that in a second, but most of the diagnostics could be done from a blood count and a blood film in order to identify leukemia. But if you were able to do more in-depth testing, if there were blasts in the peripheral blood, then most of the work can be done from the peripheral blood without the need for a bone marrow biopsy, even if that is possible. Counselling of the mum, we had to consider this given the gravity of it. We thought about the setting of that conversation, ensured that she had some family support available and allowed for her privacy. And during the conversation and in preparation for the conversation, we thought having as much knowledge as possible about the diagnosis, the stage of the pregnancy, wellness of baby, etc., was important to support the discussion so that we could have a holistic approach to management. And we, like I've mentioned before, we found it useful when seeing this patient that we did joint consultations with obstetrics if time and expertise allowed. In terms of assessment of baby, we were already aware of the gestation of the pregnancy in this case, but if that was uncertain, then we would want to use ultrasound to assess for gestation and also to assess for wellness of baby and monitoring at vital time points if this is at all possible. If we think about the risks both to mum and baby, so if we're putting in the balance how the conversation should go and think about if we left the leukemia untreated, what would happen to mum and baby? And if we did treat, what would happen to mum and baby? And clearly, neither option is risk-free. Neither option is ideal. But I think mum and family had to be fully informed of what we perceived as being the risks either way. So if we didn't treat the leukemia for mum, it's clear she would have had progressive leukemia. She may have developed sepsis, and it would be likely that if we left it untreated, she would die as a result of the leukemia. Of course, in the interim, as the white count rises, it has impacts on the placental function. And we think that this is likely to result in an adverse outcome for the pregnancy also. And then thinking about the psychological impact, which we were keen to support her with. In terms of the baby, if we didn't treat the leukemia, we thought that the outcome for the baby was likely to be adverse, either with significant health problems or in fact intrauterine death. Um, thinking about the impact of any other complications to mum and how that might impact on baby, for example, anemia, DIC, leukemic cells causing placental dysfunction, etc. If we treated the leukemia with chemotherapy, um, there's the potential psychological and emotional impact of decision making around a pregnancy. So, if she was earlier in the pregnancy, we may have discussed termination for medical reasons versus continuing pregnancy whilst exploring treatment, which may in itself bring increased risk to the pregnancy associated with the treatment and an impact on the developing baby. It's also worth noting that the side effects from chemotherapy can be very significant in any patient, never mind if they are also pregnant. So the impact on nausea and vomiting and sepsis, etc. And also that patients do die as a result of this treatment. So we had to factor that in. In terms of what happens to baby when we treat with chemotherapy during the pregnancy, well, I guess the outcome would be dependent on many factors, including maternal wellness, the gestation of the pregnancy, any complications that are encountered, and the treatment that we gave. Some drugs may be teratogenic, but also pose significant risk at different gestations. So anthracyclines in the first trimester during cardiac development would be contraindicated due to the risk to the developing fetus. And later on in pregnancy, although it's not completely contraindicated, anthracyclines are more likely to cause a much deeper cytopenia than some other chemotherapy options. And so it may be a risk if you're planning delivery of the baby. So when we thought about management, to determine our options, we involved the mum and family in discussions with our MDT, taking account of the gestation of the pregnancy. And for this case, we were fortunate. She was 31 weeks with a viable, healthy pregnancy. We treated complications with transfusions, neutropenic fever. We thought about our choice of antibiotics and whether that was safe in pregnancy. And bleeding symptoms, we gave platelet transfusions and local treatment where appropriate. She did have a prophylaxis with antimicrobials, ambisome and acyclovir and azithromycin, and we started the thromboprophylaxis when the platelet count allowed. We did do other investigations to assess safety, so we did an echo, an ECG, and a liver ultrasound, but these would not have been essential in order to proceed. And then planning for the future, we wanted to clearly document and communicate with the involved teams about what the intended plan was at that time point and the future planning. And then we have had since a discussion around future fertility impact. So in the first trimester, things to consider would be the risk of spontaneous miscarriage, which is much higher in women who have leukemia than in the background population. If a patient presents during the first trimester, we would normally have a conversation, depending on the type of leukemia and the need for treatment, with regards to termination for medical reasons to allow for optimal treatment of the patient. Whilst that's very sad and a difficult conversation, we do empower people with all of the knowledge and let them to come to their own decision making around that, and we would support them whatever they decide. But continuing the pregnancy in this setting very early in a pregnancy is likely to result in an adverse outcome both for mum and the baby. Many drugs used may result in congenital malformations. So in the first trimester, there's about up to a 20% risk of major malformations when chemotherapy of any agent really is used during the first trimester. During the second and third trimester, chemotherapy is less likely to result in congenital malformations, but there is an increased risk of late miscarriage, intrauterine growth restriction, and neonatal neutropenia and sepsis. And chemotherapy is commencement of chemotherapy in a safe fashion is advisable until it is timely and safe to deliver baby. So if the pregnancy is beyond 32 weeks, it could be considered safe practice for early delivery of the baby to allow for optimal treatment of mum. But mum has to be empowered with the knowledge and counselled every risk of all the risks at every stage. The long-term impact of the infant is not known, and of course there are risks of preterm delivery associated with prematurity. And we also be very careful about the timing of chemotherapy in the third trimester, ideally aiming to have chemotherapy more than 3 weeks before the planned delivery point in order to minimise the risk of neonatal bone marrow suppression. Planned delivery is easier to manage than spontaneous labour, hence why we opted for induction of labour in this setting. And it is generally considered that an elective caesarean should only be recommended for obstetric indications, and that a vaginal delivery would be the safest modality here, assuming that there are no other contraindications. Given that the patients may have a low platelet count or a low neutrophil count, it's generally advisable that patients avoid having an epidural analgesia during the delivery. And it should be considered normal practice for patients to have some prophylactic antibiotics administered during and after the delivery in order to reduce the risk of infection. So mum and baby thoughts for postnatally: antibiotic prophylaxis if needed, tinzaparin, so for up to 6 weeks post, as long as the blood counts are safe, and timely recommencement of chemotherapy. So in this case, we restarted when the baby was 3 weeks old, and that the standard regimen was followed thereafter. The guidance would suggest that patients receiving any of the prophylactic drugs or chemotherapy should avoid breastfeeding, which is another huge undertaking and sadness for many of these women. But there will be a risk for most of these drugs to the infant, as most of it is transferred in breast milk. But we did carefully assess each of the drugs that we were given before giving this advice. So if we think this is what we have done in the UK, and we have this sort of model has been tried and tested a number of times, but where resources are limited, I think just wondered whether we should open up a conversation and perhaps ask some questions around some of the challenges and management considerations in an environment where resources are limited. So I'm just trying to move my screen in case anybody wants to ask any questions while we're having a look at this. But please just interrupt if there's anything that you want to add. So one of the things, challenges wise, is that leukemia in pregnancy is rare, and it's thankfully rare. But how do we identify women who are potentially at risk of how do we identify the women whose blood counts are perhaps not quite as we would expect in pregnancy, or the symptoms are not as quite as we would expect in pregnancy, and when should we think about leukemia? Because the fact that many of the symptoms overlap and many of the problems that you see in the blood tests overlap with a otherwise healthy pregnancy, it can lead to delays if we don't think about it. So I wondered, I know that there was discussion about a patient that had been treated locally, and I wondered, or had been identified locally as potentially having leukemia in pregnancy. So I don't know if anyone's got any comments or anything they would like to ask, but I guess we just need to think about how we would identify these patients that need more investigations. Um, so has anyone got any comments or anything they want to ask around that?
I was just going to jump in, Michelle, and say, is Orton on the call at all? Are you there, Orton? No, I don't think that
That's
it
okay.
is. That's okay. Um, and one of the things that I know was we talked about a fair bit when we visited Lusaka was just the importance of that link up with your laboratory. These are the kind of cases where, if you are concerned that they are challenging, but actually you need to be going up to the lab and finding one of the laboratory hematology consultants that they're there, they're willing to help, and actually you can learn an awful lot from what is a test that is available. It's just making up a blood film and having a look down the microscope at the
Yeah,
cells. So I think that's really the first step is looking at the blood under the microscope and linking up with your laboratory hematology consultant to when you come across these difficult cases. Sorry, I jumped in,
yeah.
Michelle.
No, not at all, Jill. That's great. I'm absolutely correct. I think the thing that I've highlighted here is that we do an awful lot of tests in the UK system. But in actual fact, if you think that someone, I think it's trusting your instincts. If something doesn't quite add up, and the blood counts aren't right, then absolutely go into your hematology laboratory, asking for a blood film, and it'll be very quick and easy to determine whether there are leukemia cells present or not. And then I guess the next question is there the opportunity to do any follow-up testing with flow cytometry, for that to be sent off? And if you were to do that, what would the turnaround time be like? Because I guess the thing is, if you confirm acute leukemia, there are many other things to consider in the grand scheme, but quite how you would manage that would very much depend on whether we think it's AML or an ALL. And sometimes you can tell from a blood film, but sometimes not. But I think the main thing here is that for most patients, we could probably get most of the information we need just from a blood count and a blood film, and perhaps some more sophisticated tests on the peripheral blood. But a bone marrow aspirate and biopsy is helpful, but it's not necessary to make the diagnosis. And turnaround times, I mean, I think if the turnaround times to do any additional testing is quite long, you might not get the answer in time. And so a decision might need to be made with what resource you have available in terms of treatment. And I'll come on to that in a sec. Um, in terms of imaging, as I've mentioned, ultrasound is critical for fetal monitoring, gestational age determination without radiation. But I guess in this situation, we already knew the gestation of the pregnancy, but I have had two patients present much earlier in pregnancy where the gestation of the pregnancy wasn't entirely known. I also had someone who thought that they were 20 weeks pregnant, but actually when and hadn't had a scan, they had recently moved to the UK, and when we scanned, actually they were still in their first trimester. So I think knowing gestational age would help with some decision making. Um, Other considerations where resources are limited, management strategies. So I'm fortunate. I work in a tertiary hospital in the UK where I have all of these expertise on hand. But and we were able to easily collaborate between the sites with a haematologist, obstetrician, neonatologist. But just thinking in advance, who do you have in your MDT? Where are they located? How can you contact them? And I guess if you need to ask some advice, there are many haematologists, and including myself, that would be very happy to offer remote support with these cases. Um, in the first trimester, thinking about what would be reasonable and feasible to do if a diagnosis is made, and consideration of whether a patient can be referred for termination for medical reasons in order that they could pursue treatment if it's possible. But it would generally not be recommended that treatment would be delayed until the second trimester, given the risks involved to both mum and baby. In the second and third trimester, depending on the type of leukemia, you could use some standard chemotherapy if it were available and you were able to get it. Um, but there is a lower risk of malformations in the second, third trimester, but it still is not without its risks. So I think it's just thinking ahead, what drugs are available that would cross over any AML or ALL if you were in an emergency situation and needed to use some. Um, and then thinking about supportive care, so treating infections, managing anemia and thrombocytopenia. And in the UK, I think up until the recent years, all of the advances and improvements in outcomes in patients who are treated for leukemia have all been due to better supportive care. So trying to reduce the risk of infection to these patients, thinking about whether there is access to antimicrobial prophylaxis and how safe the ones that you have available are during pregnancy, prophylactic transfusions of blood and platelets. And I've mentioned in the UK that we use CMV negative blood products, but is this even a consideration? And it was interesting. I had a look before joining to see what the rates of CMV seropositivity are in the Zambia population. And it looks like from other studies that have been done, it's about 83% of patients who've been screened for CMV are positive. So, I guess you may have a limited blood pool, and I suspect the likelihood of finding people who donate that are CMV negative is likely to be small. Um, and so I'm not sure whether this is even a consideration in the population, but the reason that we would do it is to try and reduce the risk of neonatal CMV infection. And then delivery planning. So if the pregnancy is beyond 32 weeks, I think it would be generally accepted that you could consider delivery of the pregnancy if it was required, but also that you could continue on treatment until it's safer, until the blood counts are better. Um, but what we would generally advise is that the safest time to deliver the baby would be when the blood counts are optimum. So if they can go ahead with some chemotherapy or some treatment, the best time to deliver baby would be in the window where the blood counts are a bit more stable in order to prevent hemorrhage, but also infection. As I've mentioned, in terms of diagnostics, peripheral blood and film review with ability to further test would be your standard testing. And like I said, there isn't an absolute need for a bone marrow biopsy if you've got blasts in the peripheral blood. Um, and when you think about treatments, so protocol simplification, so we have got standard protocols, but your access, I'm sure, is very variable to what you can get at certain times. And so it's just thinking about is some essential drugs that might help to treat if you have access to them. So ATRA in APL could be life-saving. Steroids, steroids alone in ALL can induce remission, but steroids in combination with vinca alkaloids may be sufficient in order to induce a remission. And cytarabine, whilst it wouldn't be standard to give it as a single agent, it would be a good agent in order to reduce the bulk of AML and to try and allow for some normal marrow function in order to safely deliver a baby, for example. Um, Also think about your use of telemedicine, so teleconsultation if you're able to, with tertiary centres for specialist input and preventing unnecessary travel for the patient. And like I said, I'm sure that there are many people that would be happy to be consulted if there was any discussions that are required, and I'm very happy to be contacted myself. Um, Individualized care. So in a very limited setting, if you had a very difficult case where you have identified a leukemia in pregnancy and the outcome is likely to be poor for mum and for baby, then a focus on palliative care may be appropriate, and delivering the baby early to give it the best chance if it's near viability would be the best option with the hope of some aggressive therapy, but parallel planning alongside that the outcome may not be good for mum and for baby. This is just a slide for some resources that I've found useful over this time. In addition to this, there are many, many case reports of modified treatments that can be used for treating leukemia in pregnancy. So, if you've got very nuanced decisions to make. There are many case reports out there where they have tweaked this, that, or the other, or used something that's off standard protocol. And I found that very helpful just in trying to aid with decision making when I'm faced with a leukemia in pregnancy. So I'll end there. If anyone's got any questions or wants to pick up on any of the discussion points.
Thanks, Michelle. I was just going to add a comment if I can. And
Please. Yeah.
I think, to say this goes back again to experiences of visiting Lusaka, that the once the patients, once there's a suspicion of leukemia or a diagnosis of leukemia, the patients would then be moved to be looked after under the malignant hematology team, obviously. But I think very similar to in the UK, there's such a huge importance about the obstetric teams remaining involved in the management of that woman. So I'm a haematologist, and I rely heavily on my obstetric colleagues when looking after these ladies, really, and around the sort of the optimum treatment, and often the timing of birth. It's quite nuanced, and actually, I think that's where you really do need your obstetric team's wealth of experience of looking after pregnancy alongside the hematology. It's a really good example of how you absolutely do need multidisciplinary care. So that was just a
Yeah.
comment more than anything. So I'd
Yeah.
encourage people to keep, do can do. There's sometimes a feeling that you're sort of handing the patients over to never looked after the malignant team, but actually there's still a huge amount of obstetric experience that I rely on when looking after these ladies.
Yeah, I would absolutely agree. And our focus sometimes in conversations was always very different, and the different facets to which the obstetrics team can bring to these joint consultations. I've learned so much by doing these joint consultations about managing leukemia and pregnancy. I've never done obstetrics during my training, other than an undergraduate level, and so it's been lovely to work alongside and sort of develop our knowledge alongside each other in order to optimize the care for these women. So yes, I absolutely agree that having your MDT of people with different expertise really does allow for the best outcome, whatever that may be.
Are there any imminent questions? As ever, we're more than happy to be emailed about questions or queries after the event. And also all of the sessions, we record them, and these will be uploaded onto the BSH website. So these are accessible afterwards and also to share. So if there's no more questions, I think we'll draw the session to a close. And just once again, thank you all for attending, and thank you, Michelle, for that excellent presentation. It's very much appreciated.